Greetings, Quest judging team. My name is Aziz Abdel Karim. I'm a second year cardiology fellow, and I'm here to take you over my presentation for my research project on mitral annular disjunction. My supervisor is Dr. Luis Afonso, and he is one of the leading pioneers, as you know, in the on echocardiography field. Uh, so to quickly take you lay the foundation for my research. Um, so what is mitral annular disjunction? Yeah, basically, mitral annular disjunction is a separation between the mitral annulus and the ventricular muscle, the LV ventricular muscle, and um, and it have been first described. It have been described for a couple of decades, and it have been described in people who have mitral valve prolapse. And the theory was that those people, due to excessive motion of the mitral valve and the mitral annulus, they will develop a separation between the LV muscle wall and the annulus. And with this excessive motion, they will start to develop fibrous tissue in that area between the annulus and the LV muscle wall. And this illustration can tell you clearly what's the difference between both. So this is normal anatomy. You can see that the LV muscle wall is directly connected to the annulus and the atrial muscle wall, whereas on the right you will see there's this blue fibrous tissue, an area of separation between the LV muscle wall and the between the LV muscle wall and the mitral annulus. And this is another illustration that can explain, that can show you clearly the what mitral annular disjunction looks like. So it have been described in the literature, but its significance, um, and it went under the radar for a while because no one could tell what's the significance of it. And initially, it was thought to happen only in people with mitral valve prolapse, as 40 to 90% of them can have this MAD on their echocardiogram. But it's have been also described in people who don't have even um, any form of prolapse. So, and again, as of recently, there have been instances of patient having sudden cardiac death or malignant arrhythmias and have this MAD with no other explanation of why they had this sudden cardiac death. So there have been a focus on it, specifically in the last 5 years, uh, to kind of tell which patients have this increased risk of malignant arrhythmia. Um, and then um, again, as you know, echocardiography is available, and it's the cheapest way of cardiac imaging. So if we can get answers from echocardiography on which patients have increased risk of arrhythmia versus not, then that's a huge deal and cutting a form of a cutting edge research that we can add to the literature. Again, many of the standard echocardiography metrics, as ejection fraction or the severity of mitral regurgitation, or the type of mitral valve prolapse, or even the age of the patient, that have been in previous research, it did not show any difference between people who get sudden cardiac death and people who don't. Um, so in this research, we try to introduce studying global strain, which is a specific advanced form of tracking on muscle deformation on echocardiogram using uh, advanced Doppler and echocardiography to kind of see if there's a difference between the two patients, two subsets of patients who develop arrhythmia and not. And from previous research on the topic, we know that there are an area of, as I mentioned, that area of fibrous tissue of the muscle replaced with it that could form an nidus for what we call re-entry for patients to have ventricular tachycardias. Um, so what did we do? We basically did a retrospective cohort. We went up to 5 years behind to kind of see people who have this mitral annular disjunction from the database at our Ecolab and at Wayne Health Clinic Ecolab. And overall, we were able to find 69 patients with non-duplicate like echoes and complete clinical data that we include in the study. Actually, the total patient were 110, and based on exclusion, for example, the lack of event monitoring, the lack of EKGs, or the lack of complete data, we ruled them out. And as I mentioned here, the inclusion criteria is the presence of MAT and presence of and then the presence of EKG, or a form of presence of event monitor, Holter monitor, or being in the hospital for more than 48 hours with telemetry monitoring. Uh, and then we define arrhythmia as life-threatening ventricular arrhythmia, which is sustained VT, VFib, or if they have a history of aborted sudden cardiac death. And out of those 69 patients, 14.5% made that arrhythmic endpoint. And so, um, as we were collecting the echocardiography data, we collected huge comprehensive data between the two groups, which is basically we focus now on LV dimension by indexing it to body surface area, LA size, the MAD distance, presence of absence of MAD distance, which is basically the distance between the LV wall and the mitral annulus, and then MR based on severity, and the most important to get LV strain by speckle tracking. And we divided it into global, regional, and segmental strains. And normally there's 17 segments of strain. And then this is an echocardiographic representation of MAD, the way it looks on different views. We mainly use the peristernal long axis view to measure the MAD distance. And then we also did further stratification based on the presence of or absence of arrhythmias. And for analysis, we used Stata, and we did univariate analysis, and then did multivariate logistic regression to see the independent predictors of arrhythmic events on those patients. And this is a division of the basic data, which is 31% of them had any form of arrhythmia, which is larger than the population. And in those people who had arrhythmias, what percentage of them? 45% have life-threatening arrhythmia. 55% almost had none. And then the type of arrhythmias we find. So SVT, AFib, PVCs, those are the non-life-threatening. The life-threatening are the VTs, VFib, sustained VT, sudden cardiac arrest. So the results. So the mean age of the cohort were 58. Arrhythmia patients tend to be younger, and um, and that was not statistically significant. But there was trend of having more younger age for the people who developed arrhythmias. 58% were women, and then the presence 95% of patients had MVP, mitral valve prolapse. For comorbidities, there were the rates of comorbidities were equal between the two groups, and specifically, we had to make sure that people who have previous MIs are equal between the two groups to prevent co-founding. Um, and again, with regard to symptoms, we noticed that people who have history of syncope were more frequent in the arrhythmia group, and that was statistically significant. Like if you have MAD and a history of syncope, your odds are 6.4, and that was 6.4 of having a life-threatening arrhythmia than people who did not report history of syncope. Other clinical variables were not different between the two groups. The biggest difference is in in analysis between the two groups is that people who have larger LV size, specifically when we index them with a median 4.8 by 4.5, and higher LV and systolic and diastolic diameter in both cases, uh, which was statistically significant. Again, also there's a slight increase in the LA size. Uh, and the most important was there was a difference in the average MAD distance, uh, which you can see here between the arrhythmia and non-arrhythmia group, that people who had arrhythmia, they had a mad distance of 10, whereas people who did not have arrhythmia on average had a mad distance of 8. And the same was also for specific regional strain in the mid inferolateral segment. There was a significant difference between the two groups. Um, so, um, so the key echocardiographic differences, as I mentioned, 10.4 and 8.99 difference in the mad distance between the two groups. Again, the MR severity did not differ between the two groups. Uh, LV function was preserved in the both groups, 60% in average. Um, Again, the regional difference. We notice that there's a specific segment, which is a mid-inferolateral LV segment, when the strain is lower, which was minus 12. Normally, strain is minus 18 to minus 22, versus normally strain in people who do not have an event uh, predict people who have higher risk of having life-threatening arrhythmia. And we did classify them categorically, and we did classifying them as a continuous variables, and we did the analysis in both. And this is the representation of people, representation like a heat map for representation of the people who have different strains in different segments. And there is 18 segments that we compared. And a big thing in this is that people who tend to have arrhythmia and MAD, they tend to have worse basal strain than people who don't. And usually the apex is usually preserved uh, in those people, which we call a strain gradient gap. Um, and again, when we did univariate analysis, um, the results were consistent. There was a higher LV diastolic diameter. LV systolic diameter was significant. MAD distance with each 1 millimeter increase, the odds ratio increased by 1.17, which tells you that your odds of arrhythmia increased 17% with each millimeter increase in the mad distance. In the atrial left atrium, there was association, but there was no statistically significant difference in the univariate analysis. Age was the same, being a female. There's trend toward higher odds, but it was not significant. But syncope was significant, as I mentioned. Um, and this is a forest plot to show the representation of the significant predictors on univariate analysis. And when we build up our multivariate analysis, uh, uh, like a our like multivariate analysis, like a algorithm, to see which are the predictors for arrhythmias. The ones which were the LV and diastolic diameter in centimeters, with the odd of 4.3, LV and systolic diameter, left atrial area, MAD distance, and that specific segment of mid-inferior lateral strain that is very close anatomically to where that MAD is present. Um, and which significant odds ratio. Um, so this is indexing. Um, so um, and again, that odds ratio of 1.017 is per each 1% decrease in the strain of that segment. Um, Again, this is another illustration of the difference between the arrhythmia and the non-arrhythmia group. Um, and again, EF, MR severity, and other conventional echocardiographic metric did not differ between the two groups. Uh, so, what's the nutshell of this research? So, the nutshell of this research is that, hey, there are certain specific criteria that if a patient have MAD on echo, you can focus on to classify and stratify people with high risk. The biggest one is the MAD distance. If it's above, it's close to 10, then those people need very closer monitoring. And then if there are abnormal chamber size, abnormal increased LV dilation, increased LA size, and again to focus on that key, which is area of strain, which is the inferior basal strain. If that strain values, because as we know, strain usually go down before even other metrics go down, those people weren't had like a more focused or a more aggressive form of monitoring. Um, and then syncope. If patient develops syncope, then it's a warning sign that this patient need more aggressive form of cardiac defibrillator and other. Um, and then as an interpretation, we understand that there is that hinge point because there were alternative theories. Some people were saying that there is a fibrosis in the papillary muscle or other areas. Our research kind of confirmed that, hey, there is a hinge point. There's fibrous tissue at that area. Those fibrous tissue will lead to VT. Um, and focus on that specific segment to classify or to stratify the risk for your patient. Again, there were some infrareceptal involvement in the strain map we provided, but were not significant. But in general, the global LV strain, the apical LV strain is usually preserved. Um, and there is a conceptual model we kind of we which is the annular ventricular decoupling that, hey, scarring of this basal septum, that inferior-basal myocardium is the answer for why those patients get sudden cardiac deaths. Um, and this slide go over the implication of the finding we have, which is on surveillance, if you find PVCs originating from that area, consider doing a more aggressive monitoring, or even consider doing an ICD on those patients. And then enhancing risk stratification, as I mentioned, and the role of primary prevention in those patients. And this finding also can help with patient counseling. Future direction. So basically, this research is more of an original uh, studying into this pathophysiology of MAD, and we were able to prove that, hey, strain and getting a complete strain picture in people who have MAD, making sure that the quality is great on those strains, which we're going to describe in our published manuscript. Uh, can help you stratify those patients, and this can even build the foundation, because in our study we were able to provide detailed data of different type of strain: global, longitudinal, segmental, regional, and global, which can form a foundation for people if we want to study this further um, into going forward. um, and we hope that we can help guide more prospective studies or even like trials on ICD intervention in those patients. So it will be a huge help to the literature. Um, so in summary, MVP patient MAD, it's indicates structural and electrical vulnerability even when the EF and the MR are normal. High risk phenotypes are people with enlarged distance, LV and LA dilation, and focal strain reduction in the inferior lateral muscle like region. Um, Clinical impact: do routine echo, get a correct assessment of the MAD distance, do segmental strain, not just global is not sufficient, do segmental strain in people who have MAD, and do targeted monitoring, and even we can suggest prophylactic intervention in people who have this criteria we find in our research. I would like to thank you for your attention, and please, if you have any questions regarding the project, you can reach out to me or Dr. Afonso. Thank you so much.